Hi, welcome to the podcast. This is Dr. Dorai Ramanathan, head of the Oncology in Zahra Hospital Dubai. I'm joined in by Dr. Hussam Al Qudah. Dr. Hussam, welcome to the podcast. Do you want to introduce yourself?
Thank you. I'm Dr. Hussam Al Qudah, consultant urologist and head of urology department in Zahra Hospital Dubai.
Welcome. We thought it's very important we discuss about the male health awareness, which we're celebrating in November every year. Tell us about the importance of this month and what it really means to men's health.
It's really very important because men's health usually comes at the end. And this month we should really increase the awareness about doing prostate cancer screening, testicular tumor screening, and awareness about men's health in general, because they don't take care of their health. We should advise them, encourage them to man up and do checkup.
That's exactly right. Actually, we always say this. They act tough. They don't want to show that there is a problem. And like I mentioned, it's previously also, it's a sexual health. They don't want to talk about it, about urinary symptoms. They don't talk about it. So you mentioned prostate cancer and prostate symptoms awareness. What do you expect men to do? When do they should come and see a urologist?
First, let's say that at the age of 45, I should start seeing my urologist, because we need to take a baseline studies for our evaluation of simple blood test called the PSA symptom score to see how bad are his urinary symptoms, if the patient have any urinary symptoms like frequency, urgency, going to the toilet too many times, waking up at night, even if we do not have any symptoms.
Sure.
Because prostate cancer may be a silent disease.
Correct.
We should come and do a simple blood test.
A screening test.
And a questionnaire with a doctor. Sometimes we need to take it a little bit more to do an ultrasound. People are afraid of the finger test, doing a prostate finger test, which we do not do anymore. Unless there is really a big need for it, we do not do it anymore.
Perfect. So they don't have to fear about the digital examination anymore. So it's a blood test and maybe a urine test, as simple as that actually. So we talked about younger people coming as a screening, of course with symptoms, so they can come to you as well. How important is screening?
Screening is very important because there's a big gap between the cure, between a patient who discovers his cancer in early stage and between a patient who discovers his cancer in late stages. Now, I would say that in our part of the world, let's say 10 years ago, probably about 70% of patients, when we discover them, it's really late. So I cannot do a surgery for them and cannot cure them from cancer. We have just to do a palliative treatment or try to just to restrict the cancer growth.
Correct.
And
just to control the tumor.
Control it, yes. So, but now, fortunately, it's the other way around. We have more patients who come to us and at early stage, so we can cure them from cancer. The difference is really, if they are cured, they can live a normal life. They don't have really to suffer from all the additive treatment that they will need if the cancer is not controlled.
So like any other cancer, early diagnosis cure at the end of the day, and it's very important. So we recommend PSA screening and seeing the urologist for most of the men, you say at age 45 onwards, right?
Yes.
Take us through the journey of somebody coming to you. They're afraid, or they're coming for screening, or they might have some urinary symptoms. How do you approach this patient? What is the little journey that they have to go through?
It's simply first we ask them about the symptoms. If the patient has any symptoms about urinary symptoms, like if he goes to the toilet frequently, if he has to strain, to push to pass urine, if he feels that his urine stream is a little bit weaker, if he has to wake up at night to go to the toilet. Also, if it has any effect on his sexual function, because that's an important part of the questionnaire. How good is his erection and how frequently he gets the relation with his wife. Any other symptoms, we also ask in details about the symptoms.
Detailed history.
Other than this, if things are fine, he has minimal symptoms or no symptoms, it's just after that we ask them to do a PSA test, a urine test, and sometimes if there are symptoms we do an ultrasound and flow test.
Sure.
Ultrasound is simple. Everybody knows what's the ultrasound. It's echo for the prostate and the bladder before and after urinating to see
how much the retain,
how much he still have urine in his bladder, and the way when he pees. It's a simple uroflow where he pee in a special toilet that shows us how good or poor is his urine stream.
So that's perfect, actually. So it's a very outpatient based, a lot of it is. So you listen to the story, you do a blood test, you do the ultrasound pretty much in the center. There is not much invasive procedure involved at the initial stage. We talk about PSA, prostate specific antigen. We know it's prostate specific, but then we know that just because it's high doesn't mean it's cancer.
Yes.
Can you explain people that it can be any other symptom, any other reasons?
Now, PSA is an enzyme that may go up with other diseases. So it goes up with all prostate 3 problems, which are the infection, prostate enlargement, and prostate cancer.
Correct, yeah.
Now, so that's why the higher the PSA is, the higher chance of having prostate cancer. But it may also, as we said, it may go up to 20. Normally, like it's say, if somebody is 45 to 50 years old, it should be less than 2.5.
Yes.
That's why we go with the age-specific PSA. We have also other types like free PSA, PSA density. Depending on the size of the prostate, depends on what's the age of the person, we can evaluate the risk of having prostate cancer. So it tells us the risk of prostate cancer, but we have always to think about the other disease of the prostate. Prostate infection is more common in younger men. Prostate enlargement will happen in every man. If I live long enough, I will have prostate enlargement. Every man will have it. But it depends on how big is the prostate, the PSA will go up. Normally it goes up. That's why we screen, and after 1 year we repeat again the PSA. Because the PSA should go only like 0.3 or to 0.4 per year. So if it's going faster than normal, this gives us the risk of prostate cancer.
It's very important that an expert who understands PSA is managing this rather than anybody at the end of the day. And patients don't need to panic just because of the PSA, but depending on the age, like you said, age-specific PSA, very important. So that's great. So now, of course, a lot of things is not prostate cancer. We treat everything, but if diagnosed with a prostate cancer, and how bad it can be. I mean, we talk about low grade, we talk about intermediate grade, high grade. Again, what is the general approach for somebody who has been diagnosed with a prostate cancer? So,
to diagnose prostate cancer, after the ultrasound, if the PSA is high, if we are suspecting, God forbid, prostate cancer, we go for an MRI of the prostate. We do not go for a biopsy anymore without doing an MRI. The MRI can, like for the breast MRI, classify the patients from 1 to 5, how high is the chance of having prostate cancer. So if it's 3 or 4 or 5, these patients will go for a biopsy called Peyraud's classification.
Correct.
Simply, it is we do now. It's not a transrectal ultrasound biopsy. We do a perineal biopsy, which is MRI-guided. The technology is much better, and the accuracy is much better to diagnose prostate cancer. So, if we find prostate cancer in a patient, it depends on how bad is the grade. The MRI will tell us if it's localized within the prostate or it's out the prostate. Is it localized? Is it a low grade? Some patients even you can go for surveillance. We can just observe the prostate cancer. So it is that, as we said, this disease, we need to differentiate between the low grade, which is a disease that is very slow growing, will not affect the patient life, and the disease that is really a fast-growing, high-grade prostate cancer that has the chance of damaging or affecting the patient's life.
That's the message I wanted to say. So first of all, depending on the age, if it is a low grade, we might not do anything apart from active surveillance, which as a team, we always discuss as a team in our tumor board and discuss what to do with this patient. And active surveillance, what would that mean for a patient actually, if you have to do?
After surveillance, it means that we just follow up the PSA itself. Like every 6 months or 3 months, we repeat the PSA for the patient. After 1 year, we may do an MRI or a biopsy again to see if there is any change. If the PSA is going up, if there is any change in the how bad the cancer cells look after 1 or 2 years of doing the first biopsy. Now, if the patient is also the other important thing is if the patient has if the patient is 75 years old, let's say, and he has a low chance of this tumor, we say that it's low chance of affecting his life, will be leaning more towards active surveillance more than active treatment. So
there are multiple criteria to consider.
That's why it's not a one-man show. It is treating cancer patient is not anymore a one-man show. That's why we have a tumor board. We sit, me, you, the urology department, the oncology department with the radiation oncology, and we discuss the case by case. It's a tailored treatment according to the case. The important thing the patient should know that he should go to a center where all the treatments are available, where there's a full team, and where everything can be done for the patient, so he does not have to, and he trusts the system, so he can be evaluated in the right way.
Of course, I'm talking to the head of the urology here. I mean, what does it mean for a patient to have a prostatectomy? And what would you say about the robotic prostatectomy with the traditional conventional prostatectomy? What is the difference for
robotic
a patient?
prostatectomy is really, it's a beautiful surgery actually. It's a surgery for the prostate where you are able to reach the prostate with a 3-dimensional view, with a very accurate picture, so you can do the perfect job removing the prostate with saving the nerves, saving the muscles that are responsible for continence, able to control the urine after the procedure. This is what the patient is afraid of. The procedure is it's a very, very accurate procedure with the robot. We control the robotic hands, so we can do the job in an excellent way. The patient usually stays in the hospital for 1 or 2 nights after the procedure. It is now after the procedure we have to I would say educate the patient about what may happen, and because you have to wear a catheter for the procedure for like 10 days, and we have to educate him about how to take care of it, what to do after the procedure. But now it's a standard of care. Nobody should be doing he can go for an open prostatectomy, but it's for his, I would say, for his results, for his outcomes, for rapid going back to normal life, faster recovery. Doing a robotic surgery is the best.
That's my understanding too, actually. So people were scared about prostatectomy because of the risk, like you said, the incontinence risk, the failing for erection and various things. Now with robotic, the outcome is much better. I mean, we are not saying it's zero, but it's much, much better with robotic. So we offer that in our Zahra Hospital, right? A robotic prostatectomy.
Yes. For that, we actually get referrals from other hospitals to do these cases, and it's a standard of care, I would say, for prostate cancer.
Perfect. Very briefly, I mean, because I, as an oncologist involved in the discussion, we also talk about radiotherapy, and patients who are, potentially for treatment, we can offer radiotherapy as well as, surgery, depending. Again, we discuss in the tumor board, and we talk about the role of radiotherapy, role of surgery. There is no head-to-head comparison, but, some situations both are equally good. So if a patient has radiotherapy and they have started to see a failure with prostate cancer, how comfortable is one to offer them a salvage prostatectomy somehow where they can go back and remove the prostate? Is something widely practiced, or is it in a specialized center?
It is really in a specialized center. It's really not a very, that's why we say to the patient always when they sit and discuss with us, if I go for surgery, if I have a tumor coming back, I will go for radiation therapy. But if I have radiation therapy and the tumor comes back, going for surgery is not as easy journey as if there was no radiation therapy.
I say the same thing. I think so. That's why the initial decision is very important for the patient, actually. Yes. Follow-up of these patients.
It's a simple follow-up whereby as we said, it's a team evaluating the patient. We see them, you see them, and we evaluate them for a PSA recurrence. If they need the PSA starts going up in the future, what to do, and we evaluate also by nuclear scans to see if there is any bone metastasis, any lesions going outside the prostate area. It's a journey.
Absolutely.
And surgeons, medical oncologists, radiation oncologists, all of us are here to treat the patient in the proper way of getting treated.
Absolutely. So I think, we can discuss the hormone therapy, we can discuss about various things, but I think the idea is about creating awareness to find out at an early stage, So like we summarized that it is screening, PSA screening, if with or without symptoms, there is a certain age you should approach the specialist, and then they will take you through the journey, and finding something at an early stage is going to make sure that we can cure the patient, and chances of leading a near normal life is going to be very high. So although we can offer them multiple discussion about the various therapies that is available, we keep that for advanced cancers. We don't have to dwell on it too much. What is a message to our people who are listening to the podcast from your end?
It's really to come and get forward and get tested. We will encourage our ladies to encourage their husbands to. I know, that's what happens. Men's health is really not the priority, and we in this month we would like to increase the awareness about it. We care about bringing food to the table, but we should take care, because if I'm not healthy, if I don't take care of my health, I will not be able to continue the good job that I'm doing at my work. We should take care and do the tests. We should get screening. We should care about our health, exercise, stop smoking, and get early detection.
Thank you very much, Dr. Hussam, for joining the podcast, and I hope it was a useful discussion today. Thank you.